Hello and welcome everyone. Today we start with day 2 of our 100-day must know series. We are covering cardiology right now. The source of information for this series is the esteemed textbook First Aid for USMLE Step 1. I encourage you to refer to this resource for further learning. Before we dive in, I would like to take a moment to connect with you on social media. You can find links to all my channels in the video description below. Additionally, I have created a Telegram channel where fellow doctors can support each other throughout their USMLE journey. Feel free to post your doubts or queries, and more experienced doctors will be happy to help. If you are confident in your knowledge, please don't hesitate to assist others as well. Now let's get started. I will strive to move at a brisk pace to cover as much material as possible within a short span of time. Let's read about cardiac output equations. Stroke volume is calculated using the formula stroke volume is equals to end diastolic volume minus end systolic volume. Ejection fraction is calculated using formula that is stroke volume divided by end diastolic volume, and we already know that stroke volume is equals to end diastolic volume minus end systolic volume. Ejection fraction is index of ventricular contractility. It is decreased in systolic heart failure. It is usually normal in diastolic heart failure. The normal ejection fraction is 50 to 70%. Cardiac output is calculated by multiplying stroke volume and heart rate. As per Fick's principle, cardiac output is equals to rate of oxygen consumption divided by difference in the arterial oxygen content and venous oxygen content. In early stages of exercise, cardiac output is maintained by increasing heart rate and stroke volume, whereas in later stages, cardiac output is maintained by increasing heart rate only. The stroke volume plateaus. Diastole is shortened with increasing heart rate, example in ventricular tachycardia, which will result in decrease in the diastolic filling time, decrease in the stroke volume, and decrease in the cardiac output. Now pulse pressure, which is simply the difference between the systolic and diastolic blood pressure. Pulse pressure is directly proportional to stroke volume and inversely proportional to arterial compliance. Pulse pressure is increased in aortic regurgitation, aortic stiffening due to the isolated systolic hypertension in older adults, obstructive sleep apnea due to increased sympathetic tone, high output states, example anemia and hyperthyroidism. Exercise. In the transient phase, pulse pressure is decreased in aortic stenosis, cardiogenic shock, cardiac tamponade, advanced heart failure. Mean arterial pressure is calculated by multiplying cardiac output and total peripheral resistance. MAP at resting heart rate is equals to 2 by third of diastolic plus 1 third of systolic, which can also be written as diastolic plus 1 third of pulse pressure. Now let's look at Starling curves. Force of contraction is proportional to end diastolic length of cardiac muscle fiber, that is preload. There is increase in contractility with catecholamines, positive inotropes, for example dobutamine, milrinone, digoxin. There is decreased contractility with loss of functional myocardium, example in myocardial infarction. Beta blockers, non-hydropyridine calcium channel blockers, heart failure. To reinforce your learning, let's work on some questions together. From now on, I will remain quiet during the questions and a timer will appear on the screen. For easier questions, I will provide less time, while more challenging clinical vignette type questions will have more time allocated. Let's proceed. The correct answer is A, 100 ml. The correct answer is B, diastolic heart failure. The correct answer is A, 50 ml. The correct answer is B, Rate of oxygen consumption divided by difference between the atrial oxygen content and venous oxygen content. The correct answer is C. Aortic regurgitation. The correct answer is C. 4.5 liters per minute. The correct answer is A. 60 ml. The correct answer is A. 40 mmHg. Now let's read about resistance, pressure and flow. Volume flow rate is equals to flow velocity multiplied by the cross-sectional area. This is analogous to Ohm's law for electrical circuits, which was potential difference is equals to current multiplied by the resistance. You need to know that capillaries have highest total cross-sectional areas and lowest flow velocity. Pressure gradient drives flow from high pressure to low pressure. Arterioles account for most of the total peripheral resistance. Veins provide most of the blood storage capacity. Viscosity depends mostly on hematocrit. Viscosity is increased in hyperproteinemic states, for example, multiple myeloma and polycythemia. It is decreased in anemia. Now let's read about cardiac and vascular function curves. First one is inotropy. If there is change in the contractility, there will be altered stroke volume and altered cardiac output, venous return, and right atrial pressure. Inotropy is increased by catecholamines, dobutamine, digoxin, exercise. It is decreased by heart failure with reduced ejection fraction, narcotic overdose, sympathetic inhibition. Next graph is venous return. If there is changes in circulating volume, this will result in altered RAP, altered stroke volume, and change in the cardiac output. Positive shift is seen with fluid infusion, sympathetic activity, atriovenous shunt. Negative shift is seen with acute hemorrhage and spinal anesthesia. Now, total peripheral resistance graph. If there is changes in the total peripheral resistance, there will be altered cardiac output. The change in right atrial pressure is unpredictable. The positive shift in the graph is seen with vasopressors and the negative shift is seen with exercise and atriovenous shunt. Changes often occur in tandem or you can say coordinated way. It may be reinforcing or compensatory. Now let's solve some questions. The correct answer is C. Hyperproteinemia. The correct answer is C. Capillaries. The correct answer is B. Decreased blood viscosity. The correct answer is C. Narcotic overdose. The correct answer is B. Increased sympathetic activity. The correct answer is A. Administration of dobutamine. The correct answer is A. Phlebotomy. The correct answer is B. Exercise. Now let's see the phases and change in the left ventricle. Look at the image. The black loop represents normal cardiac physiology. Isovolumetric contraction phase is period between mitral valve closing and aortic valve opening. It is also period of highest oxygen consumption. Systolic ejection phase is the period between aortic valve opening and closing. Isovolumetric relaxation phase is period between aortic valve closing and mitral valve opening. Rapid filling phase is period just after mitral valve opening. Reduced filling phase is the period just before mitral valve closing. Now let's talk about heart sounds. S1 is for mitral and tricuspid valve closure. It is loudest at the mitral area. S2 is for aortic and pulmonary valve closure. It is loudest at left upper sternal border. S3 is heard in early diastole during rapid ventricular filling phase. Best heard at apex with patient in left lateral decubitus position. It is associated with increased filling pressures, for example, mitral regurgitation, aortic regurgitation, heart failure, thyrotoxicosis. S3 is more common in dilated ventricles but can be normal in children, young adults, athletes, and pregnancy. S3 is due to turbulence caused by blood from LA mixing with increased stroke volume. S4 is heard in late diastole. It is due to turbulence caused by blood entering stiffened left ventricle. It is best heard at apex with patient in left lateral decubitus position. It is seen in high atrial pressure. It is also associated with ventricular non-compliance. Example, hypertrophy. It is common in older adults. Now let's study jugular venous pulse. A wave represents atrial contraction. It is prominent in AV dissociation, also known as Cannon A wave, and also prominent in increased RV and diastolic pressure from any cause. A wave is absent in atrial fibrillation. C wave represents RV contraction. It is due to closed tricuspid valve bulging into atrium. X descent represents atrial relaxation and downward displacement of closed tricuspid valve during rapid ventricular ejection phase. It is reduced or absent in tricuspid regurgitation and right heart failure because pressure gradients are reduced. V wave represents increasing right atrial pressure due to increasing volume against closed tricuspid valve. Y descent represents right atrial emptying into right ventricle. It is prominent in constructive pericarditis, absent in cardiac tamponade. Now let's solve some questions. The correct answer is D, increased wall tension. The correct answer is C, S3. The correct answer is A wave. The correct answer is D, reduced filling phase. The correct answer is D, Y descent. The correct answer is C, heart failure with reduced ejection fraction. The correct answer is A, atrioventricular dissociation. The correct answer is A, hypertensive heart disease. Now let's start with pressure volume loops and valvular disease. In aortic stenosis, there is increase in left ventricular pressure and end systolic volume. In mild case, there is no change in end diastolic volume. Along with that, there is decrease in stroke volume. Ventricular hypertrophy leads to decrease in ventricular compliance, leading to increase in end diastolic pressure for a given end diastolic volume. In aortic regurgitation, there is no true isovolumetric phase. Along with that, there is increase in end diastolic volume and stroke volume, and there is loss of dicrotic notch. In mitral stenosis, there is increase in left atrial pressure, decrease in end diastolic volume because of the impaired ventricular filling, and decrease in the end systolic volume and stroke volume. In mitral regurgitation, there is no true isovolumetric phase. There is decrease in end systolic volume due to decreased resistance and increased regurgitation into left atria during systole. There is increase in end diastolic volume due to increased left atrial volume or pressure from regurgitation, leading to increased ventricular filling. There is increase in stroke volume because of forward flow into systemic circulation plus backflow into left atria. Now let's solve some questions. The correct answer is C. No change in EDV, increase in ESV and decrease in SV. The correct answer is C. Aortic regurgitation. The correct answer is B. Decrease in EDV and ESV. The correct answer is B. Increase due to increased left atrial volume and pressure. The correct answer is D. Loss of dicrotic notch. The correct answer is D. Decreased compliance due to ventricular hypertrophy. The correct answer is B. Increased regurgitant volume into the left atrium. The correct answer is A. Increased preload due to aortic regurgitation. Now let's read about different types of splitting of S2. Physiologic splitting. Inspiration leads to a drop in intrathoracic pressure, which increases venous return, leading to increased right ventricular filling, leading to increased right ventricular stroke volume and increased right ventricle ejection time. This results in delayed closure of the pulmonic valve. Additionally, decreased pulmonary impedance or increase in capacity of the pulmonary circulation also occurs during inspiration, which contributes to delayed closure of the pulmonic valve. Wide splitting. It is seen in conditions that delay right ventricular emptying. Example, pulmonic stenosis, right bundle branch block causes delayed pulmonic sound, especially on inspiration. This is an exaggeration of normal splitting. Fixed splitting. It is heard in AST. AST leads to left to right shunt, which increases the RA and RV volume, leading to increased flow through the pulmonic valve and delayed pulmonic valve closure, independent of the respiration. Paradoxical splitting. Heard in conditions that delay aortic valve closure. Example, aortic stenosis, left bundle branch block. The normal order of semilunar valve closure is reversed in the paradoxical splitting. P2 occurs before A2. On inspiration, P2 closes later and moves closer to A2, paradoxically eliminating the split. On expiration, the split can be heard, opposite to the physiologic splitting. Now let's solve some questions. The correct answer is B. Decreased pulmonary impedance and increased RV filling during inspiration. The correct answer is B. Pulmonic stenosis. The correct answer is C. Equal splitting during inspiration and expiration. The correct answer is B. Left bundle branch block. The correct answer is B. P2 occurs later and moves closer to A2. The correct answer is A. Increased splitting. The correct answer is B. Fixed splitting that does not vary with respiration. The correct answer is C. P2 occurs before A2 and the split decreases. Now let's read about auscultation of heart. In the aortic area, you will auscultate for systolic murmurs, for example, aortic stenosis, flow murmurs, for example, physiologic murmur, and aortic valve sclerosis. In tricuspid area, you can auscultate for holosystolic murmur, like tricuspid regurgitation and VSD, ventricular septal defect, and diastolic murmurs like tricuspid stenosis. In pulmonic area, you can auscultate for systolic ejection murmur, for example, pulmonary stenosis, atrial septal defect, and flow murmur. In mitral area, at the apex, you can auscultate systolic murmur like mitral regurgitation and mitral valve prolapse, and diastolic murmur like mitral stenosis. At left sternal border, you can auscultate systolic murmur like hypertrophic cardiomyopathy and diastolic murmur like aortic regurgitation and pulmonary regurgitation. The correct answer is A. Aortic stenosis. The correct answer is D. Both B and C. The correct answer is A. Atrial septal defect. The correct answer is A. Mitral stenosis. The correct answer is C. Left sternal border. The correct answer is A. Aortic regurgitation. The correct answer is A. Increased flow across the pulmonary valve due to the atrial septal defect. The correct answer is C. Pulmonary hypertension. Now, this is a table showing how different physical maneuvers affect cardiovascular changes and heart murmurs. So, for the maneuver which is standing or Valsalva in the staining phase, the cardiovascular changes are that preload decreases, leading to decreased left ventricular volume. The murmurs that increase with this maneuver are mitral valve prolapse with decreased left ventricular volume, causing an earlier mid-systolic click, and hypertrophic cardiomyopathy with decreased left ventricular volume. The murmur that decrease with this maneuver are most murmurs because of the decreased flow through stenotic or regurgitant valves. Okay, so there are two maneuvers here, passive leg raise and squatting. For passive leg raise, there is an increase in the preload which leads to increase in the left ventricular volume. For squatting, there is an increase in both preload and afterload, and that results in an increase in the left ventricular volume. Now talking about murmurs that change with these maneuvers. Most murmurs increase with these maneuvers because of increased flow through stenotic or regurgitant valve. But murmurs that decrease with these maneuvers are mitral valve prolapse with increased left ventricular volume causing later mid-systolic click and hypertrophic cardiomyopathy with increased left ventricular volume. Moving on, the next maneuver is hand grip. With hand grip, there is an increase in afterload, which leads to increase in the reverse flow across the aortic valve and an increase in the left ventricular volume. Now talking about murmurs that change with this maneuver. Murmurs that increase with the maneuver are most other left-sided murmurs like aortic regurgitation, mitral regurgitation, ventricular septal defect. Murmurs that decrease with the maneuver are aortic stenosis due to the decrease in trans-aortic valve pressure gradient and hypertrophic cardiomyopathy due to an increase in left ventricular volume. During the maneuver of inspiration, there is an increase in the venous return to the right side of heart and decrease in the venous return to the left side. In terms of maneuvers, most right-sided murmurs increase with inspiration. Conversely, most left-sided murmurs are noted to increase with expiration. Now let's solve some questions. The correct answer is B. Increase in intensity. The correct answer is C. Squatting. The correct answer is B. Increase in intensity. The correct answer is B. Decrease in intensity. The correct answer is C. Aortic stenosis. The correct answer is B. Right side of heart. The correct answer is A. Mitral valve prolapse. The correct answer is B. Aortic regurgitation. As your homework for today, I encourage you to read the relevant pages in the first aid for USMLE Step 1 book until I have covered today's material. You all did a fantastic job today showing focus and dedication. Thanks for the support. Subscribe and share. Don't forget to join the Telegram and WhatsApp channels. The links are in the description.